And welcome everyone. I'm Beth Stewart, Director of the Texas Oral Health Coalition, and on behalf of the coalition and our conference partners, the Texas Health Institute and the Texas Department of State Health Services Oral Health Improvement Program, I'd like to thank you for joining us for the second session of the 2020 Texas Oral Health Virtual Conference. There we go. To introduce our second presenter for today's session and serve as moderator is Dr. Rhonda Stokely. Dr. Stokely is a member of the Texas Oral Health Conference Planning Committee and serves as the State Public Health Dental Director and the Texas Department of State Health Services Health Screening and Oral Health Unit Manager. Dr. Stokely, the controls are yours.
Thank you, Beth. And thank you everybody for joining us today. So I want to ask you before we get started, have you given syphilis any thought at all, hardly, since you were in school? Or when you were receiving the training for whatever field you work in now, did you receive any kind of training about syphilis? Now's the time we need to dust off those pathology books and learn more about syphilis, especially here in Texas. So I'd like to introduce to you today our speaker, Dr. Patel. Dr. Patel is a board-certified oral and maxillofacial pathologist who graduated from Howard University College of Dentistry in 2011. He completed his residency in oral pathology at Texas A&M University College of Dentistry and is currently a full-time faculty member in the Department of Diagnostic Sciences. He maintains a clinical practice, seeing patients who suffer from various oral diseases, and participates in an active surgical pathology practice. He is involved in research with the College of Dentistry and through collaborations with other institutions. Dr. Patel serves as a reviewer for various reputable journals and is currently the section editor for the Oral and Maxillofacial Pathology Case of the Month for the Texas Dental Journal. He has also authored several peer-reviewed articles. So I'd like to hand it over now to Dr. Patel.
Good afternoon, everybody. Hopefully everybody can see and hear me. It's good to be here. I'd like to start off by thanking the collective. It's been a monumental effort to transition a CE opportunity like this online. So a special thank you to everybody who's kind of made this available for all of us. So before I get started, I'm going to talk about the fact that this is kind of a white whale to me, syphilis, not just as a clinician, but also as a pathologist. But as opposed to being a true white whale, I know this exists. Okay, so we know it's out there, but I've been chasing it. And there's a reason it's called the Great Masquerader, because it can truly mimic something simple as a reactive process to something more complex like a drug reaction. And in some cases, something as worrisome as a malignancy, not just clinically, but as well under the microscope, histopathologically. So again, thank you to the collective and the committee for approaching me about this. I'm very excited to talk about it. I'm a very casual sort of speaker, and I like usually having a lot of interaction. So I wish I kind of had some built-in laughs and things like that to help me kind of along the way. But you can still type in ha 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 if that's okay. So before I move on, a special thank you to Beth Stewart and Dr. Rhonda Stokely for kind of guiding me and giving me a little bit of advice along the way. So thank you both and being patient with me. All right, here. Whoa. All right. We start off usually in an informal fashion. Everybody likes to show you these family photos where, the family's all looking at the camera. They're really professionally taking photos. Well, in reality, life is really like this. And again, my son's here in the back doing whatever he wants to do. She has me wrapped around her fingers since day one. And the rock in our family, the one who holds the glue that holds this together and allows me to work for 10 to 12 hours a day and just have fun, is my wife here in the front. So these are my angels. This is his serious face. And when he showed me this, or when I asked him to be serious and he showed me this, I told him two things. I said, hey buddy, don't take life so seriously. And two, don't ever play poker. All right. And that's where we insert the ha 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 right there. All right. And this is my princess here. You would think that she's been on a 20-mile hike. This is about 5 minutes into our walk. And she proceeded to sit down and then lay down. When I asked her, baby, what's going on? And she looked at me and she said, Daddy, I'm tired. Mind you, there are people walking by us, looking at us like we're negligent parents. So this is my life. All right. So moving on to syphilis, the objectives today, and I'm not a big fan of math, but I've come to realize in my career how important statistics are because it really places a value on the epidemic spread of disease. And it really drives home points when you can tell people that these are the numbers that we're seeing in our state or in our country. So we're going to focus a little bit on statistics initially, and then we'll move on to understanding what it means to diagnose syphilis, not just what it means to your patients, the individuals that come into your practice, but what it means to us as a society and in general. And then last, but definitely not least, we'll review the clinical manifestations of syphilis. As a clinician, we should all be aware that evaluation of the patient starts when you review the patient's questionnaire. And we, as healthcare providers, oral healthcare providers, have a tendency to focus on our neck of the woods, no pun intended. But we need to evaluate the person as a whole and be able to, kind of put together the clues that they're presenting with to come up with an adequate diagnosis and really utilize interdisciplinary healthcare. All right, and that's where we're heading, and that's where we need to be. A lot of public healthcare systems, I did work in a federally qualified health center for some time, have the ability to have an open communication between dental and medical departments as well as other specialty providers, which makes it really easy to get in touch with people that you can use as resources in your practice. So what is syphilis? Syphilis is an infectious disease process that's caused by a bacterial organism called Treponema pallidum. Not everybody knows, but it's not just Treponema pallidum, it's then a subspecies pallidum. There's two other subspecies. One of them is called endemicum, which causes a similar disease process to syphilis, which is syphilitic in nature. And then there's one that's associated with more of a tropical disease, which is called Petunia. But we're going to focus on Treponema pallidum, subspecies pallidum, which is the the defining or causative organism for syphilis. And this is what it looks like. It is this spirochete or corkscrew type organism, and this is an evaluation of this organism under dark field illumination, and it's transmitted through direct sexual contact. Okay, it's important to know that this organism cannot survive outside the host. So you're not going to get this infection after it's been sitting on an exposed surface for a prolonged period of time. It needs the host to survive. It can be vertically transmitted from mother to child, and that can be done through a few different ways. One is through the process of childbirth, where the fetus becomes exposed to the maternal fluids, and again, the mom herself is usually infected. The second way is actually the fact that this organism can cross over the placental barrier. Okay, so it can happen really early in the developing fetus. Thirdly, during breastfeeding, a child can become infected, but it is not through breast milk like we have with HIV. Okay, so the breast milk is not the infectious source, but if the mother has an open sore or a lesion in the areola or nipple region, and the child comes in direct contact with that, that could be a mode of transmission. All right. So the disease process has been around for hundreds of years. There's early descriptions in the mid to late 1400s, and historically it's been referred to by different names because, again, it is variable in its clinical presentation. It's been referred to as Louis or the Great Pox. And in our country, it has a little bit of an infamous history with the Tuskegee Institute in Alabama, where African American males that were afflicted with syphilis were intentionally treatment was withheld as these individuals were monitored over the course of time to see the spread of syphilis and the stages of syphilis and what happens as this infection progresses. So a little bit of a marred history in our country with syphilis itself. So before we move on and focus in on just syphilis, I'm going to take a brief moment here to talk about the fact that there is a epidemic across our country in regards to STIs or sexually transmitted diseases or infections in general. Okay, chlamydia, gonorrhea have been on the rise for the last half decade, Interestingly, gonorrhea, there's been drug resistance as well as not just single but multi-drug resistant strains that have developed, and it's becoming harder to manage and treat. And then when we focus on primary and secondary syphilis and congenital syphilis, we can see that there's a marked increase in the numbers of diagnoses since 2014. Okay, and this data is directly from the CDC, and I think it is updated as far as 2018 to current times. So when you look at how syphilis has been reported over the course of time, reporting actually began in 1941. And this is where I would ask you, well, what caused this drastic drop? And some of you would answer, well, it was because we started using penicillin. Yeah. So penicillin was actually invented in the late 20s, but manufacturing and mass producing penicillin to make an adequate dose from a mold at that point in time was really difficult. So it was first used in the UK, and a lot of patients that had bacterial infections that were syphilitic or non-syphilitic ended up dying from disease. So it took a little while to get the medicine over to the United States and have enough medicine for a patient to actually finish a full course that would be enough to combat a bacterial infection. So that's where we see this drastic drop. In 1943 is when we started using penicillin for syphilitic infections. But over the course of time, you see there are some bumps along the way, and they correspond specifically to what's going on in the country at that point in time. In the 60s, we have sexual revolution. In the 80s and 90s, there's a change in sexual perceptions and sexual habits. And also in the 80s and 90s here, we see a change in the demographic, okay? We go from heterosexual males and females to men who have sex with men or homosexual males, all right? And now in the last half decade or so, we're seeing this increase up to the current time, which has kind of stayed stable in regards to its gradual increase. And I'll talk a little bit about what some of the speculation is, why it's increasing at this point in time. All right. Historically and currently, the southern and western parts of the country have been infected at higher rates. And this could be due to regional differences in the demographic population, religious beliefs, and perceptions on sexual practices, okay? There's a lot of things that probably contribute to this process, but the South and the West do show higher rates of primary, secondary, and overall syphilis. So where do we stand? Where does the Lone Star State stand in regards to diagnosis? So looking at our numbers, which all of this stuff is really readily available to anybody through the Texas Department of State Health Services, or the Human Health Services Department, online. And so this is from the Texas STD Surveillance Report. And the data from 2018 shows us that in 1 year, we saw a 15.8% increase, which kind of works its way to about 8.8 residents per 100,000 that are infected with primary and secondary syphilis. Congenital syphilis, huge increase here, 123.5% increase or jump. And that goes to a large number of births, which is 91 births per 100,000, okay? And so we've seen a drastic increase in primary, secondary, as well as congenital syphilis in our state. Our state, compared to the other states when it comes to primary and secondary syphilis, is number 20. Nevada, California, and Mississippi are top 3 for primary and secondary. For congenital syphilis, unfortunately, we are the #1 state out of all reporting states, according to the Centers for Disease Control and Prevention. Okay, so we have the highest number of diagnosed congenital syphilis cases across the country. So who are we seeing this infection in? And so we're seeing this infection more often diagnosed in males, and improportionately or unproportionately, Blacks are affected at much higher rates than Hispanics, whites, and other races. And the age range spans from the 2nd decade through the 5th decade, but the highest rates of diagnoses are seen in the mid to late 30s. Okay, so mid 20s through the mid 30s and late 30s. Okay, and when we talk about which group or subset of individuals are more likely to present with syphilitic infections, the large chunk of this, again, is men who have sex with men only, okay, in regards to the reported number of cases. And there is some speculation to why there's an increase in this cohort and why it's been increasing for the last half decade. Some of it has to do with the availability of pre-exposure prophylaxis. Some people have speculated that now, with the advent of pre-exposure prophylaxis for HIV and AIDS, or HIV infection, that is changing somewhat the sexual perceptions or perceptions on sexual practices, and therefore there's a little bit of laxity there that is increasing the number of infections we're seeing. Again, this is not proven, but there are a few contributing factors, and this is one of the speculations that's out there in regards to the number of cases we're seeing currently. All right. And before I move on, I'm just going to talk to you a little bit about the cost of healthcare and the cost of STIs across the country. I was raised in an environment which is very conscious about the humanitarian side of what we do as healthcare providers. Sorry. I was never told to focus on the monetary things, but come to find out, I realized that it is important to at least understand what these things cost in regards to allocating funds and being able to prevent certain diseases if possible, to make more funds available to push somewhere else in our field. So looking at the United States across the board in general, annually for all of the STIs, the more common STIs, we utilize about $742 million a year treating sexually transmitted diseases or infections. Okay, that is a huge amount of money treating a disease that is preventable. Okay, as clinicians, a lot of you are aware that we come in, a patient comes into your practice or an individual comes into your practice, and we focus on treatment, often ignoring the fact that we need to have a discussion about prevention with these individuals. We talk about health IQ of our community. Who's responsible for that health IQ? Who's responsible for the community to be aware of, hey, this infection can cause, prolonged effects to my developing child? Who's important, who's really important and integral to that? We are, and that's not just the clinician, it's the entire healthcare team. This is a topic that's really tough to discuss, all right? Talking about sexual practices and sexually transmitted infections is not easy. And there's no magic or silver bullet to help you make this easy. But there are modes of communication that can be nonverbal, all right? CDC, as well as the Texas Department of State Health Services, have numerous educational things on their websites that you can print out, plaster across your practice, or make pamphlets for, okay? So this stuff is readily available, and we are responsible for changing the tide in the way we manage our patients. If we can prevent this, it would be fantastic. And we can actually change the way the epidemiologic kind of gradual increase goes in the future, all right? The other part of this is that it's a lot easier to talk about prevention when things are more dire, like cancer. Nobody's gonna watch a precancerous lesion grow into a fulminant cancer and cause the eventual demise of the patient. But it's important to equally understand that this is just as important in other disease processes like sexually transmitted infections. So we're the ones who are involved in our community. We're the ones who are embedded in our community. It's our responsibility not just to treat these patients, but to educate these patients because they are our community members, right? About prevention and healthy sexual practices. All right. So moving on to syphilis, we're going to talk about how this infection progresses in humans. Once an individual is infected, the infection goes through a few different phases. Traditionally, a lot of people like to refer to it as 3 phases, which are primary, secondary, and tertiary. I refer to it as 4 because latency is an active phase with defined clinical and biologic characteristics, okay? Primary phase is 3 to 90 days, and typically the lesions of primary syphilis are seen at the site of infection, okay? So this is the site of inoculation, and that's where you're typically going to see the lesions, all right? This is the phase where the organism is transmitted from one individual to another, and it begins its spread through the patient's lymphatics and other systemic organs, okay? Secondary syphilis, as defined by 4 to 10 weeks, is the stage where we have more extensive spread, and now we have more generalized systemic manifestations of the disease. It may not just be localized to the site of infection. Latency, and I'll go into detail about this when we get to latency, can vary from 1 to 30 years. And true latency, the disease is clinically quiescent. there's no evidence of clinical disease. And the screening tests that we utilize, which are highly sensitive but not specific, are typically are negative in true latency. So it can be hard to detect disease in patients who have latent syphilis. And then tertiary syphilis, it follows the latent phase, and it has the most severe complications that we'll go over as we approach that stage of disease. Congenital syphilis refers to a fetal infection. And the mother, who is the infected individual, can transmit that infection at any stage of disease, but it's actually more common in the primary and secondary stages. So again, a few different methods or mechanisms by way the fetus can actually be infected, which I went over earlier, but it's good to know that, you know, an infected mother can transmit that infection at any stage of disease, okay? So primary syphilis, and when we talk about the phases, instead of thinking about it as blocks of time, think of it as an interdigitating progression of disease, okay? It's not that, okay, this is 90 days and that's it. There's usually going to be some overlap into the secondary phases. There's going to be some overlap into latency, and then there's probably going to be some overlap into tertiary syphilis as well. So it's a gradual progression of disease that is really interdigitated and very intimately associated. Typically, the signs of primary syphilis, as defined, are seen within 3 to 90 days after initial infection. The classical clinical manifestation is what we call a chancre, and it's a small ulcerated lesion. It's typically painless, and oftentimes it's more meaty. And what I mean by that, it's more nodulo-ulcerative. There's some bulk to it. It's going to appear a little bit raised as opposed to a flat ulceration. On occasion, they can be flat and more innocuous, but more often than not, there's a little bit of a nodular ulcerative sort of disease process that's visualized. Rarely, it can present as an exophytic sort of vascular lesion. There's a reactive lesion that's vascular or vasoproliferative, which we call a pyogenic granuloma. A lot of you may be aware that's seen very commonly in pregnant females, but a pyogenic granuloma can affect the mucosa in the skin, and sometimes syphilis, primary syphilis, that lesion can look like a pyogenic granuloma or a vascular lesion. The most common site in the oral cavity is the lip, but again, it can affect any mucosal site, and it's usually at that site of inoculation. That's why we see the labial mucosa as well as the vermilion and the cutaneous aspect of the lip being more often affected than any other site. At this stage, again, this is an infection, so we may start to develop some regional lymphadenopathy, particularly as there's more progression of disease. The organism starts as its initial spread through the lymphatics at this point in time, okay? Even without treatment, these lesions will typically resolve within 3 to 8 weeks, right? So we're going to go through a spectrum of what these lesions actually look like, okay? And a lot of these, there's a little bit of variability. These are all on the lip, as you can see, but you can see there's a little bit of a raised nodulo-ulcerative process here. And that's what I mean by nodulo-ulcerative. It's not a flat ulceration. There really is a raised process, and it seems a little bit thicker, okay? And these can be a little bit more worrisome for something like a carcinoma developing on the lip, all right? And then on occasion, they can be a little bit more innocuous. This is a little bit flatter, and it seems something that could easily be a traumatic sort of ulceration. How do we define an ulcer? We define it as this yellowish white membrane, which is the body's fibrin. The body produces a Band-Aid anytime you lose epithelium, that soft layer of tissue on top, which is what we consider our skin in our oral cavity, we refer to as a mucosa. So whenever we lose that top layer of epithelium, that body forms this little Band-Aid, okay? And so it's defined by this yellowish white membrane with surrounding redness, okay? And that typically is a characteristic feature of an ulcer, all right? We go through this. Some of these can be more extensive and bring up the possibility of malignancy, particularly when they're more destructive locally. This is affecting the palatal gingiva, but you can see it's quite extensive in regards to its involvement. And in many cases, some of these are painless, but once there's enough destruction of the tissue surrounding it, you can imagine there's going to be some degree of discomfort that these patients do feel, all right? This is one on the anterior dorsolateral tongue. And you can see this is a classic example of that really thick yellowish membrane and more of that nodulo-ulcerative lesion that could easily be mistaken for something that's worrisome for a cancer, particularly given the site in this case, all right? And we'll talk about diagnosis and the fact that these need to be biopsied as well as followed up with serologic studies or other ways to actually confirm that there is a syphilitic infection later on, right? Here's another example of an ulcer, and it doesn't quite have that thick white yellow membrane as we saw in the previous slide, but this may be in the healing stages. We start to see some more epithelium that may be starting to overgrow here, but you can see that there's clearly a change from the surrounding epithelium to this area here, and a lot of this is still fibrinous in nature, and you can see kind of the pinpoint vasculature in here as these little red areas, all right? These lesions are fairly innocuous and I think could be easily overlooked. This one's even hard to tell where it is, but it's in the labial frenum here, which can be easily visualized as a traumatic ulceration, okay? So you could easily think that this is a traumatic lesion. This patient had another ulceration on the palate, which goes along with a lot of disease processes that have multifocal ulcerations in the oral cavity, like aphthous stomatitis, or more commonly referred to as canker sores, okay? But in this case, this patient did have some other intraoral as well as extraoral manifestations, and these lesions were consistent with chancres for primary syphilis. And this is a textbook example, literally, because it's the only good example I've seen of this lesion presenting as an exophytic vascular sort of process. And I think a clinical diagnosis of a pyogenic granuloma would be absolutely adequate here. Again, these patients aren't going to come into your office saying that they're sick. They're going to say that, hey, this is a recent onset lesion, and it looks reactive. The short duration makes us think it's reactive. It's only whenever we pull in the histologic findings along with more of the clinical information that we're able to come up with a good diagnosis for these individuals. And that's why, again, it's really easily overlooked and it's tough to diagnose, as it can mimic the spectrum of pathologic processes. And this slide always reminds me to tell you that our questioning and clinical evaluation, or evaluation in general, starts before the patient enters the room, okay? This patient has a chancre on his finger here. Clearly everybody can visualize. I don't think anybody would miss this because it's in an area that's exposed, and you're usually gonna evaluate your patient's exposed skin areas, okay? You're gonna look at their hands, and something this obvious would not be overlooked. However, if there's a lesion in the anogenital region, most of us that are healthcare providers, oral healthcare providers, are not gonna ask or question in more detail about any other lesions. Make it a point. When you go through the questionnaire with your patients, which everybody should do, ask them, are there any new bumps, lumps, sore spots, or any rashes that you've seen on your body? Is there anything new? Because if there is some suspicion for something that's newly formed, we can at least get the patient referred to an appropriate physician for further evaluation, or a dermatologist for evaluation, okay? So that really is, it drives home the point of clinical evaluation, how key it is to evaluate the individual, not just in our area of focus, but as a whole. All right, moving on to secondary syphilis. This is typically within the 4 to 10 week period after initial infection. There's a handful of characteristic lesions. A few of the ones that are going to affect the oral cavity more commonly than not are mucus patches and condyloma lata. Mucus patches are these sensitive white patches that may or may not be raised. Sometimes they're isolated. Sometimes they can be multifocal or multiple in one area. When there are multiple lesions in one area, they can often undergo a coalescing process to form a larger lesion. And what this is, when you look at it at the histopathologic level, it's a thickening of the epithelium with an increase in inflammation as a result of this infectious process. And over time, all that inflammation and degeneration that happens in the epithelium causes it to undergo necrosis. That means it all dies off. And at some point in time, that tissue will literally fall away as it's all dead. And it'll reveal this raw connective tissue surface that is very painful to these individuals, okay? The most common sites we see this on are the tongue, the lip, the buccal mucosa, and palate. So this is something to be aware of in these individuals. And mucus patches do have a wide range of clinical appearances. And I have a few very good examples from publications as well as texts that I'm going to show you. Condyloma lata, it's a unicorn to me as well. You know, they say that it most often mimics a viral papilloma. I have one really good example that shows this mimicking a viral papilloma. You're asking, what is a viral papilloma? These are the typical benign papillary proliferations that we see with HPV infection, okay? Condyloma lata really has a spectrum. Most often it presents as a raised lesion, and it's often mistaken for an HPV-associated proliferation. They're more common in the anogenital region. However, we do see these in the oral cavity. The interesting point here is any of these lesions of secondary syphilis can actually arise while the patient still has a persistent chancre or the lesion associated with primary syphilis. So you can have your secondary syphilitic lesions arise in the setting prior to the resolution of your primary lesions. Again, secondary syphilis is now systemic spread, so we're going to have more generalized manifestations. You're going to have painless lymphadenopathy, okay? And this is not just regional, okay? So if the patient has a chancre on their tongue, you expect to see lymphadenopathy in the cervical region in the neck because that is in the area of infection. That is where your immune system is really mounting that response to fight this infection, so the lymph nodes start to get enlarged. At this point, it's more generalized. So if it is in the cervical neck, we may actually have axillary or lymph nodes in the armpit that are going to be more palpable and noticeable. You may have had lymph nodes in the inguinal region around the genitals that are going to be more palpable and noticeable, okay, as well as other sites. In addition to that, patients may present with dysphagia, which is difficulty in swallowing, sore throat, malaise, headache, fever. Malaise is a fancy word for fatigue, fever and weight loss, as well as musculoskeletal pain. All these things have in common one thing. They're the constitutional signs of an infection, okay? So at this point, the patient may actually have the constitutional signs and symptoms of an infection. One last thing associated with secondary syphilis is this characteristic maculopapular rash that can be red, it can be hyperpigmented, more brownish, or hypopigmented, where it's a little bit more pale. And characteristically, it will affect the palms and soles, which is very unique about this disease process. The resolution of these lesions can occur without treatment within 3 to 12 weeks. However, as we progress into early stages of latency, we can still have recurrences of these secondary lesions, right? And this is kind of the prototypical example of a mucus patch. This is somewhat raised. You can tell it's this whitish lesion on the lip here. It shows a little bit of thickening, like I mentioned, compared to the surrounding tissues. Here's an example where this one shows a little bit more of a serpiginous or snake-like pattern where it's kind of winding back and forth. And you can see there's multiple lesions in these cases here. And what's going to happen in some cases where you have multiple lesions like you have on the soft palate here is over time they may have a tendency to coalesce and form one larger lesion, okay? So this is a good example of a patient who had multiple lesions, and then over time those lesions kind of spread and involved and kind of intermingled with one another and form one larger lesion. These are a few good examples showing some of the variability in mucus patches. Excuse me. Here's an isolated lesion on the palate here. We have a couple on the lip. All of these look a little bit more raised. This one's a little bit more macular or more flat in its appearance. And then we have one here that's a little bit more raised and kind of little hint of this being more snake-like, which is really obvious on this one here in the commissure, okay? And in many cases at this point, these lesions are probably going to be sensitive, okay? The patient's going to at least complain of some degree of discomfort. There's so much inflammation there that it would be highly unusual to have no evidence of any symptoms in these cases, okay? And these are the best examples of that serpiginous or snake-like pattern that I've found in this publication. Okay, it's by DePaulo, and it was in a specific infectious disease journal. But you can see a really snake-like kind of winding back and forth pattern here associated with mucus patches of secondary syphilis. Here's a good example of a condyloma lata, and I think most of us would feel that, you know, it doesn't really look papillary and like a, you know, a viral wart or a papillary lesion associated with HPV, but it goes to show you that these are kind of broad-based and sessile lesions, but they are raised and exophytic, okay? This is an example of a 26-year-old male, recent onset of soft palate and oropharyngeal lesions. It's a little bit more challenging to appreciate this, but this was raised, and you can tell that there's some degree of irregularity along its surface, and it came in with a provisional diagnosis of this being a papillary lesion, okay? And this was a secondary lesion associated with secondary syphilis and diagnosed as a condyloma lata clinically after biopsy. This is a fantastic example from the New England Journal of Medicine. Again, this was a 26-year-old male as well. He came in with complaints of a sore throat and dysphagia and these white lesions in his mouth. And you can really appreciate how they're raised and exophytic in these areas. And they do look a little bit corrugated or papillary irregular on their surface. And these are all lesions of secondary syphilis in this patient. When he was asked about any other lesions, he did mention that 7 months prior, he had a lesion on his glans penis that kind of had undergone resolution on its own. Didn't think anything of it. He was afebrile at the time of presentation and otherwise healthy, according to him, okay? So again, you got to take in a lot of these clues, and that goes back to digging into the patient's history and putting the pieces together to make sure we get a focused diagnosis for these individuals. And this is, again, the papillary example I alluded to earlier. This is the best example of something that I think would be mistaken for a true viral papilloma. It really is exophytic, and it does look irregular and papillary on its surface. However, this patient had other lesions. This is a 33-year-old female, as well as an erythematous macular rash on her trunk and skin in different areas. And she was diagnosed with syphilis through biopsy as well as serologic studies. And this is a good example of the hyperpigmentation that we can see in these maculopapular rashes. Maculopapular means that they can also have a different appearance. They can be macular, which are flat and discolored. And discoloration doesn't mean they have to be pigmented. They can, well, it means they're going to be pigmented, but it doesn't necessarily mean that they're going to be brown. It could mean that they're pale, okay, or hypopigmented, or it could mean that they're red. Okay, so this is an example in a darker skinned individual where they're showing a little bit more brownish color. And some of them are a little bit more flat and macular, while others are a little bit more papular or raised, and they present as a papule. This is on the soles of an individual. This is evidence of the maculopapular rash. And again, most of these are very flat, but they show that brownish discoloration in this patient. And oftentimes we see that brownish discoloration in patients that are a little bit more dark-skinned or complected. And this is one where we have some lesions on the trunk of an individual, and they really are more papular. You can appreciate that they look raised and they're really red, all right? And the face and the neck region, they can also be involved with this rash. So again, it's not something that you're gonna just see on the trunk and the palms and soles. We can see this on the skin of the face and neck. And it's something to be aware of when we're evaluating patients in regards to oral lesions as well. All right, so moving on to latency. Latency is broken up to early and latent phases. Early phases or the early stage of latency is kind of defined as less than or equal to a year, and late latency, which I kind of like to refer to as true latency, is over a year or of an unknown period of time. And the period is asymptomatic clinically. The patients don't have any evidence. In true latency, patients don't have any evidence of disease. Again, in early latency, we may have some recurrences of some of the mucocutaneous manifestations, but during the late phases, clinically, there's no evidence of disease. It is quiet. Your screening test will be negative. The bacteria itself actually reduces its metabolism, and it doesn't replicate as readily. And so if you look at it in regards to treatment, our antibiotics that we use are penicillin, and it affects the actively replicating bacteria, okay, and it kills it. So if you don't have a bacterial organism that is replicating as often or as quickly, your antibiotic therapy is not going to be as effective. In addition to this, by this point in time, the disease has a tendency to spread into sites that are not going to be readily accessible by the antimicrobial therapies that we use, okay, the antibiotics that we use. It can cross the blood-brain barrier, which your antibiotics are not going to be of much use there, and it can cross into lymph nodes and establish a little pool of organisms within the lymph nodes, which, again, the antibiotics may not penetrate and adequately kill the organism, okay? So there's a few things why latent disease is tough to diagnose as well as manage, okay? Latency can span anywhere from 1 to 30 years prior to progression into tertiary syphilis. So tertiary syphilis, it's variable onset depending on the duration of latency, characteristic lesions, and the way I think about this is simple. I teach immunology to the dental students, and we talk about infection, inflammatory response, right? And it really is the infection elicits the body's inflammatory response that causes the damage, okay? And so the lesions we see in tertiary syphilis are a result of persistent infection and inflammation that causes damage to the surrounding tissues, okay? And this is where we see the most severe complications, right? The vascular effects as a result of persistent inflammation of the blood vessels are things like an aneurysm of the ascending aorta, which can cause aortic regurgitation and lead to congestive heart failure, okay? When it crosses over the blood-brain barrier and involves the central nervous system, we can see things like tabes dorsalis, which is a lack of coordination or a lack of coordination, a loss and lack of coordination and movement. You can see dementia develop in these patients, and paresis, which truly is muscular weakness that develops. Ocular lesions, there's truly one lesion that is associated with the eye itself, outside of a few other things, but iritis as well as panuveitis can develop in these patients and cause vision abnormalities and loss of vision. And then what we call an Argyll-Robertson pupil, okay? And this really is a sign of neural involvement. This is a sign of neurosyphilis and the central nervous system being involved. But you can visualize it by looking at the patient's eye. And this refers to the patient's pupil staying in a semi-constricted state. And whenever you tell the patient to focus on your finger, that pupil will constrict. So you can see that constriction response whenever the patient is asked to focus on an object, okay? So as you put your finger closer to their eyes, you can see that there is evidence of constriction. However, whenever you flash a bright light in the patient's eyes, there's no response, okay? A normal response would be constriction of the pupil because we need to limit the amount of light entering the eye. That way we can get a focused image, okay? And in these individuals, they have absolutely lost that response. So that you will see absolutely no response to bright light in these individuals. And that's what we call an Argyll-Robertson pupil, which is very characteristic of tertiary syphilis. These patients can also develop gummatous lesions or gummas, and these are really extensively destructive ulcerative lesions and nodular ulcerative lesions that are a result of granulomatous or persistent granulomatous inflammation. When they happen in the oral cavity, we've seen with some frequency that they involve the palatal tissues, and they can actually perforate up into the nasal cavity and destroy the septum, causing a nasal defect where you can see a depression of the nasal bridge. In addition to that, we can have a generalized involvement of the tongue and other mucosal sites. When it involves the tongue, you can actually start to get scarring as a result of the inflammation and cause a contracture and abnormal configuration of the tongue, as well as an atrophy where you lose the normal dorsal papillary appearance of the tongue. And that's really a result of multifocal granulomatous inflammation that's affecting the tongue. All right. And this is a good example of a gumma that had involved the palate and perforated through to the nasal cavity and destroyed the septum. So at this point, if you look at the patient, even in extraoral examination, you see that the patient's nasal bridge is depressed to a degree. Functionally, this is a huge issue. As you can imagine, eating, drinking, anything that requires a seal, things are going to go up into the nasal cavity. It can go either one of two ways. It can come out through the nostrils, or it can be post-nasal, which can become a major issue and a source of infection in many individuals. This is an example of a gumma that is affecting the skin of the nasal bridge here. Here's another one that is causing extensive necrosis and destruction of the tissue. And this can get deep. I showed you the example of it affecting the bone on the palate. It can burrow through bone anywhere. Okay, so this is a deep-seated inflammatory process that causes degeneration of the tissue around it. Okay. This is a good example of an interstitial or lytic glossitis. And this atrophy is not specific for syphilis. We see this with other inflammatory and non-inflammatory conditions. The classic non-inflammatory condition that causes a generalized atrophy and this sort of bald tongue appearance is anemia, whether it be B12 or iron, okay? So we can see this with other things. The fact of the matter is that a lot of these patients will develop kind of irregular areas of contracture and nodularities, which is really, you can see that more impressively here where we have this defect that is developed in this patient's tongue and this area of nodularity that when you palpate it, it is very firm on palpation. On top of that, we have evidence of an inflammatory process with areas of necrosis of the epithelium as illustrated by the white areas on this tongue. And it's really driven here where this is large areas of ulcerative of ulceration involving the tongue. And you can see there's kind of depressions and defects in a few areas as a result of scarring that has taken place post-inflammation, okay? All right, so moving on to congenital syphilis. I'm going to talk a little bit about the fact that there are two stages, early congenital syphilis and late congenital syphilis. Early stage is defined as the period where the manifestations are seen at birth to less than 2 years. And then late is typically when the manifestations start to appear after 2 years of age, okay? Again, this organism can cross the placental barrier. It maintains that ability. So infection can happen in the early stages of fetal development, and the patients will be born with actual congenital defects and anomalies, okay? And we're gonna go through a few of these in regards to making sure that you guys understand, that everybody understands what we're looking for in these patients, okay? Pregnant women with untreated or inadequately treated, the key word inadequately treated, okay? And untreated goes hand in hand with unrecognized disease. Inadequately treated primary or secondary syphilis are more likely to transmit that infection to the fetus, okay? It can happen at any stage, but it's more likely to happen in the primary and secondary stages. The other thing that's really important here is that close to half of the developing fetuses or babies that are born will be stillborn or die within the first month, or what we term the neonatal period. So, you know, it's not something that they're going to be born with some defects that we're going to be able to manage through an interdisciplinary approach. It's that the infection can cause a death of the fetus. And that's very important to get across to the individuals. Again, Texas is #1, and look at the increase in our numbers as we made this large jump from 2017 to 2018. And you could add that, hey, maybe we were getting better at reporting this. As of 2018, well, actually within the past few years, I think 2018, we did start implementing more prominent sort of restricted guidelines in regards to reporting. So females in the state of Texas are required to undergo a first prenatal screen. So they're required to go syphilis testing during the first prenatal visit, again between 28 and 32 weeks of gestation, and then again at delivery, okay? Not all states in our country have adopted the CDC recommendations, but Texas has put this into law, and so maybe that's a reason we were seeing that jump. But again, we are seeing this, and that could be from any number of things, whether it's unrecognized disease as a result of the patient not being, not being in to see a physician at all and then coming in to deliver, inadequately treated disease, and patients that are just completely unaware. And we are in the position to kind of manage these patients at every stage of this disease process and in an attempt to prevent the manifestations of congenital syphilis. So clinical signs and symptoms, the classic thing that you guys may or may not have remembered through teachings is Hutchinson triad, okay? The Hutchinson's triad or Hutchinson triad refers to 3 anomalies that we are in a particular position as oral healthcare providers to pick up on. Hutchinson's teeth, which are incisors and mulberry molars. And the incisors have a particular morphologic appearance where instead of having that trapezoid appearance where the largest mesiodistal width is at the incisal edge, they usually have the largest mesiodistal width in the middle third of the tooth, okay? And they taper to that incisal edge, which makes it look like a flathead screwdriver. Oftentimes, you also have a notch on the incisal edge that we can see. Mulberry molars refers to these molars that have really irregular sort of globular cusp-like projections on the occlusal surface. So clearly, whenever you evaluate these teeth, the teeth look abnormal. On top of it, they have a tendency to also constrict as they go to the occlusal edge. And then ocular interstitial keratitis is corneal inflammation that can lead to scarring and blindness in these individuals. And then oftentimes these individuals can also have sensory neural deafness associated with the 8th cranial nerve, which is the vestibulocochlear nerve. All right. I'll show you a couple of good examples that we have here in a second. Again, with congenital syphilis, the signs and symptoms are going to be a result of infection, and that infection elicits this inflammatory response. And you can have reactive changes or degenerative changes that happen. So patients may present with these classic characteristics of frontal bossing, a saddle nose deformity, which goes hand in hand with depression of the nasal bridge as there's destruction of the septum, Higamanaki sign, which is enlargement of the clavicle near the sternoclavicular junction, regades, which is what we term as a perioral fissuring, which gives young individuals the appearance of being much older, an aged appearance in young individuals. And that really is a result of inflammation and scarring causing contracture around the mouth. Saber shins are a periosteal reaction which causes an anterior bowing of your shin, and Clutton joints, which are enlargements of joints which are typically painless as a result of inflammation involving the synovial membranes. This is the classic appearance of the Hutchinson's incisors. Again, large mesiodistal width here as opposed to a trapezoid shaped tooth where you would be the largest width at the incisal edge, and this prominent notch that is taking place here. I think this is a really good example of this appearing like a flathead screwdriver. Okay, you can see that it kind of tapers to that incisal edge, and that really is an abnormal dental morphology for these incisors. In addition to that, we can get these mulberry molars, and they're referred to mulberries or mulberry molars, as you can imagine, because they look like mulberries, right? You have those numerous little berry-like proliferations on the occlusal surface of these teeth, many irregular occlusal cusp-like projections, which make it look like a mulberry, right? And again, it can span the spectrum. The big thing to pick up on are these certain characteristic features, but you will have dental abnormalities associated with these individuals. This is a good sign, or a good example of kind of the depression of the nasal bridge. You can see the alar and the apex of the nose are more prominent. That saddle nose deformity is probably going to be best viewed when you see the patient from a lateral aspect or a sagittal aspect, because you can truly appreciate there's a depression here, which makes it look like an area where you would place a saddle. On top of that, this individual looks much older than he is, a young man, but he has these wrinkles in this area, and that's the perioral fissuring that we associate with ragades and congenital syphilis. All right. So touching a little bit on diagnosis, it is a challenge, okay? It's not straightforward. A lot of times before I entered pathology and the field of histologic evaluation of tissue, I was like, oh, well, hell, I give these guys a sample and they're gonna tell me by looking under the microscope that this is X or this is Y. Unfortunately, it's not that easy and it's not that simple. So a biopsy or a smear can be done of an active lesion with dark field illumination. It'll show you that corkscrew-shaped organism like I showed you in the initial slides. However, that doesn't necessarily mean that this patient has syphilis, okay? You have to have clinical correlation and the understanding that the oral cavity has normally occurring flora that are treponemal in nature, okay? Don't look exactly the same. So you have to be able to visualize where exactly this organism was in the biopsy. Is it truly infective, or is it secondary and saprophytic in a different location? And we use that in conjunction with the clinical findings as well as serologic studies to confirm a diagnosis of syphilis. So it is very complex, okay? We have treponema micro and macrodentium that occur in the oral cavity as normally occurring flora, T. mucosum as well. In periodontitis, we have T. denticola, which is an offending organism, a virulent organism that's found in periodontitis, okay? Biopsies can be done, and we can utilize special stains, which are silver stains, that can show us the organism as well in the tissue that's sampled. Again, that's not going to be specific. You really have to correlate it to where the organism is found, as well as the clinical lesion. What are we seeing, okay? We can also use immunohistochemical studies, which is a fancy sort of thing that we do nowadays, where you have antibodies built against a specific protein from that organism. Interestingly enough, and not many people know this, but the other treponemal species will cross-react with the specific IHC or immunohistochemical studies that are meant for treponema pallidum, okay? So again, it's not specific, and not everybody knows about this cross-reactivity. The classic example I have for you guys for this is a general pathologist had consulted me about the suspicion for syphilis in a patient. The patient had a degree of surgical procedures in an OR setting, and the hospital had received the specimens, and it was labeled as granulation tissue. We want to rule out anything else. Clearly, with chronic periodontitis, we are aware as oral pathologists that you can have a predominant type of chronic inflammatory cell infiltrate. General pathologists, when they see this specific type, they associate it with a worrisome process or something infectious like syphilis, okay? And in that setting, the decision was made prior to consultation to go ahead and order a specific stain for syphilis organisms. It came back positive. However, the fact that treponema denticola has been identified and cross-react with these studies in tissue samples has been illustrated in the past, and the evidence that this patient likely had periodontal disease, which was confirmed after a clinical conversation with the clinician, you have to be aware that these findings are not necessarily definitive, and we don't make the diagnosis just based on visualizing that organism. Okay, we're not there just yet, all right? So there can be some cross-reactivity, and that can be a pitfall for those who are not aware of this evidence of cross-reactivity. Additionally, histologically, just like clinically, this can also mimic other disease processes, from simple reactive processes to drug reactions, allergic processes, as well as things that are worrisome for malignancy. Other testing can be done, such as specific immunofluorescent antibodies, nucleic acid amplification, which is going to be highly specific and sensitive, and then serologic studies. And so this is our last part here, where we talk about serology and treatment. Serologic studies is broken down into non-specific and specific. VDRL, which everybody should at least be aware of, and RPR are great screening tools for syphilis, okay? And VDRL stands for Venereal Disease Research Laboratory, and this was the laboratory where this test was developed. It is not specific for syphilis, the organism, but a protein that the organism produces, okay? These antibodies in VDRL testing are against that protein, okay? Interestingly enough, that protein can be found in mycobacterial infections associated with leprosy. It can be found in infectious mononucleosis, which is a viral infection. It can be found in lupus, which is an autoimmune disease. It can also be found in certain drugs which elevate this protein in the body, okay? So you can have false positives for a few different reasons, all right? So both of these are great screening tools and are highly sensitive, but they're not specific. And that's why if the proteins that are being produced by the virus, which are usually there in high levels in the primary and secondary stages, this is a great screening tool to find it, okay? In the latency, in latency where we don't have active replicating virus, that's when these are going to be negative, okay? Because there's not as much protein being produced, and it may not be enough to actually be picked up by these antibodies. In addition, you can have false negatives in patients who are markedly immunosuppressed, okay? So that's something to be aware of. Usually these screening tests that are non-specific are followed up with specific antibody testing, and there's a few different mechanisms of specific testing. There's some hemagglutination assays, and as well as antibody testing, okay? Antibody testing is highly sensitive and specific, but you have to understand that it may not be active infection, as positivity will remain for a prolonged period, if not life, in many of these individuals, so tissue sampling may be necessary. And my last slide here, treatment is very easy. It's penicillin, all right? The beauty of penicillin. It can vary depending on the patient's situation. The first-line treatment of choice is benzathine penicillin G. Benzathine makes it longer acting. It slowly makes the medication dissipate over a longer period of time, so we have a longer acting effect. Primary and secondary are typically treated with a single dose, whereas latency and tertiary is intramuscular doses once a week every 3 weeks, okay? If the patients are allergic to penicillin, doxycycline is an excellent second-line choice. Outside of that, other medications like tetracycline, erythromycin, as well as ceftriaxone have been used with some good benefit because of the fact that they can have anti-trypanosal effects. And to be aware of the fact that while you may have a clinical and serologic cure, if the bacteria evades the lymphatics and the hematogenous spread, if it crosses over to the blood-brain barrier and gets into the central nervous system, you're not going to be able to kill it, okay? And if it gets into the lymph nodes, you're not going to be able to adequately erase or kill that bacterial organism. So these patients, while they may be clinically and serologically cured, may not truly be cured, and that's why monitoring and follow-up with infectious disease or physician, or if you're in the position to follow up with patients, it is necessary to do that in these patients, okay? One last point, after introduction of the antibiotics, some of these patients will undergo what we term a Jerisch-Herxheimer reaction, and that is a reaction to the endotoxins that are a byproduct as you cause that bacteria to undergo death as a result of the penicillin, okay? So these endotoxins are released and that bacteria dies, and your body's immune system mounts a marked inflammatory response to those byproducts. So you have cytokines and all these different specific antibodies that are being released. And so these patients will develop fever, as well as myalgia and a few other clinical signs and symptoms. They may have exacerbation or worsening of their skin disease. And it's usually 2 hours after you administer the first dose of penicillin. And most patients you can monitor, and it's a self-limiting process. Some patients you may have to actively treat or monitor in a hospital setting because they are at a risk for undergoing shock. Okay. So my resources are outside of the cited journals and books, our oral maxillofacial pathology text, which is our Bible written by Neville Dam, Angela Chi, and Carl Allen, is what I use. It has a small 6 or 7 page section about syphilis, which is just phenomenal. CDC, Texas Department State of Health Services, okay? These are excellent resources where you can download material for free to make available to your practicing population, okay? Communication is not just verbal, we can do it non-verbally through various methods, so that's one way to do it. So now I feel fairly confident that you guys all know about syphilis, and as Sir William Osler said, he or she who knows syphilis knows medicine. So you guys are ready to go out there and practice as clinicians and providers in general, or as practice as part of the team, and you know syphilis well. So he was a great clinician. He's the one who started, one of the founding fathers of Johns Hopkins and the modern way we do residency and clinical practice in medicine. Patients always give me fun stuff. This is from one of my patients. I thought she was going to give me sweets, and then she pulled this cartoon out of a comic. Insert laughs here. Everyone loved working with Dr. Patel. It's me holding the paddles. Apparently, it's me holding the paddles, saying beer. So thank you all for your attention. You guys have been phenomenal. I know I'm running a little bit over time, but here's my contact information. And I think we have a few minutes maybe to take some questions.
Thank you, Dr. Patel. I thought that was really, really good. I'm really glad we invited you to come and speak. Unfortunately, we are out of time for questions. So I know that we did receive a few. Please email Dr. Patel to get your questions answered. And I'm going to go ahead and hand over to Beth so she can give the closing logistics.
Well, thank you, Dr. Stokely. And thank you, Dr. Patel. That was really an informative and it's a fantastic presentation. Thank you so much. And thank you, Dr. Stokely, for serving as moderator for the presentation. I do want to reiterate from the beginning, in case some of you missed at the housekeeping, that a recording of each presentation will be posted on the conference website the following week after each session process. The recorded versions on the conference website are for edification only, so we cannot provide CE for those. Thank you again, presenters and moderators, and thank you, audience, for joining us today. Have a pleasant afternoon, everyone, and we'll look forward to seeing you next week for our third session of the Texas Oral Health Conference.